Welcome everyone to today's webinar, Get Out of Crisis Mode, How One Iowa Hospital Used Predictive Analytics to Optimize Staffing Practices, Improve Nurse Satisfaction, and Cut Costs. I'm Mackenzie Bean, Managing Editor for Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. This session is being recorded and will be available after the event. You can use the same link used to log into today's webinar to access the recording. At this time, I'm now pleased to introduce today's presenters. Brian Dickerson is the Senior Director of Workforce at Hospital IQ. Brian has worked for healthcare workforce management for over 30 years with extensive experience in time and attendance, scheduling, patient classification, payroll, HR, and talent management. Shauna Gunn is the Manager of Operations at MercyOne Medical Center, Des Moines. Shauna has worked at MercyOne for over 10 years with broad experience in all aspects of nurse staffing and management. I'm now going to turn the floor over to Brian to begin today's presentation.
Okay, well, thank you much, and thanks to everybody for joining. Today we're going to talk about the staffing process that was implemented here in MercyOne in Des Moines, and we're going to go through three areas. The first one is we recognize that in all of our installations that one of the most challenging part of staffing is really finding time to do what we need to do. So we basically came in and we streamlined the staffing process, working with partnership with MercyOne, and basically allocated, saved time to turn around and allocate to the proactive process. So in step one, we'll talk about what we did in that process savings. And step two is really taking a portion of that time that we saved from the nursing managers in the staffing office and allocating it to being proactive and really working to be prepared in advance for what's coming the way from the future patient needs. And really also how we created a culture of transparency and teamwork to really work together on the units for staffing. And lastly, we'll talk about some of the outcomes, some of them being financially driven, but also how it's made a difference in the time savings and allocating staffing, floating, and the things that have improved not only from a financial standpoint, but also from the staff experience, both on the leadership side and the floor staff. Before we get into Shauna's piece, I wanted to talk a little bit about predictive analytics and really what we accomplish from being able to see the future. And really it's the gift of time for better decisions, and really taking the staffing and patient flow aspect of healthcare and giving some advance notice when there's both opportunities and problems coming around that will create challenges. And those things that gift of time is really relevant and can drive financial type improvements where you're able to see the future. You can understand in the staffing standpoint how the allocation of incentive pay is working, what you need to allocate, and you can limit that and control that. And it also can help with operational efficiencies where if you're looking at patient flow, do we have a problem in the next couple of shifts where if we don't get some patients out, it's going to create a staffing problem or it's going to create a boarding issue and so on. So there's really big organizational improvements. And then from the workforce, I think it's extremely important. Giving that time to see what's coming really helps with that stressful healthcare leadership problem, and really kind of the title of our session here and reducing the crisis mode. So Shauna will spend some time really talking about that. And really also if we pre-align the staff to the expected patients, we're limiting the amount of time where there's that mismatch of staff to what patients are in the unit, and how does that help drive better health care. And then from the patient standpoint, back in the workforce, it's really about proving that experience for the workforce. From the patient standpoint is, maximizing the length of stay. We've all been in hospitals where we were told we were going to get discharged, and we wait for 5 hours because there was some little thing that got missed that caused us to delay, whether it was the order or some last-minute test, but really forecasting where those bottlenecks will be. So when you think of predictive analytics, we're going to talk about workforce today, but there's a much bigger picture around the entire workflow in healthcare. Lastly, patients, it's really about reducing the length of stay and better aligning the staff to their needs and having that set up. So I'm going to turn things over to Shauna, and she can talk about the experience here at Mercy.
Hi, thanks for joining us today. Starting off with our challenges with staffing, this is really what highlights my passion with this work with workforce plan and staffing, nurse staffing in general. At MercyOne Des Moines, we're not unique in our nursing shortages. It's felt nationally, and then also Des Moines is an insurance hub here for the nation, so nurses in this region have opportunities to leave the bedside, and I feel that our acute care is most impacted by this because oftentimes nurses right out of school start in acute care, gain some experience, and move on to other roles. So my passion really stems from working as a resource pool nurse that was deployed with the schedule and oftentimes found myself on 3 different floors with 3 different groups of patients in a 12-hour shift, and then also as a direct nursing management leader where you felt like you were constantly feeling like you were staying an extra 4 hours and really struggling with that work-life balance because the gaps in staffing weren't known, weren't proactively worked on, and just really trying to find that work-life balance. Nursing itself has a high turnover related to the burnout and the hard work that it has, and whatever we can do to remove those staffing barriers regarding it will help with that. So this work has really helped us trigger those nursing shortages, find where the areas are, and deploy our targeted resource pool to those units that are having those turnovers, share staffing to help support those units during that time, and really helped us get out of a unit-level staffing protection. So we were functioning in silos. We talk about in the early days of shared staffing where we were really finding that one floor was maybe having a really great day. They had plenty of staff, maybe staff to do admit discharges, help with some of those just additional support pieces, where there's another unit 2 floors up that was really struggling with their quality and safety ratios because we were really functioning in staffing silos. Along with that, also, we were utilizing a lot of incentive pay and overtime with functioning in those staffing silos. We weren't functioning as a division transparently with our staffing to be able to know where those resources were and really understand what our workforce as a whole was and be able to allocate the resources where they were. So going back to that core staff floating, we're also finding that core staff do not like to leave their home units, just kind of naturally protective. You go to your home unit, you gain your team there and your expertise in that specialty of nursing, and the more you're floating those core staff, the less ideal it is for them to come back to work the next day, the next week, knowing they might be working a floor they're not absolutely comfortable with. So having that tool and the transparency, we're really able to keep the core staff where they are and move the resource pool staff more effectively to the area of needs where they're trained, provided the additional training to care for those patients, and also they sign up for that. They say, I want to go where the needs are, and they're compensated appropriately for that. So those truly are the staff that should be moving. So when we started out our staffing department back in 2017, we were really lacking the tools to provide that great overview of what our resources were. We started with our acute care division, and we have 8 acute care floors, and then we have our West Des Moines campus that we also help with staffing resources, and we were really struggling to have a tool. A lot of manual labor went into navigating what staff each unit had, Excel that was constantly updated and lots of physical rounding on units, multiple phone calls, and it was really tedious to try and get the resources directed where they were needed, let alone just understand where the needs were and the ability to be proactive on it. So this tool really helped pull that all together for us. So with that, started talking about just the beginning stages of our staffing office and what that looked like. We really wanted to innovate and figure out how we could do this work smarter. easier and just really understand the resources and get them where they were needed without all of the tedious, labor-intense work that was going into it. So we already were a customer of Hospital IQ, and they came in and really looked at our current workflow and quickly understood our challenges with it, that it was taking a staffing coordinator rounding multiple times on the unit, and staffing being such a fluid thing with call-ins, change in census, change in acuity, you would round, and then an hour later the staffing demands or opportunities of each unit would change drastically. So it was constantly kind of chasing your tail to determine where the staffing needs and opportunities were across a division, with the manual labor of walking around, looking at daily sheets, talking to charge nurses, pulling them away from the bedside, and really getting a handle on what that information was. So we really need to streamline that communication. It's not ideal to pull a bedside nurse, a charge nurse, away from providing that patient care, and oftentimes the staffing coordinator was also struggling with being on hold to get that charge nurse because they understood they were at the bedside, or even physically rounding and trying to kind of gain their attention for that. With all of that tedious work that was going into finding the resources, the allocation of nursing staff, resource pool, or shared core staffing was also happening at a later time. We try to get our staffing knowledge and plan in place an hour and a half before the shift, and that was really challenging with our workflow. So with the workforce plan, we're able to have that knowledge in advance, better knowledge at the unit level also of what the demands are, and allocation of the staff, and we're able to send notes through the system so we aren't pulling staff away, and we've enlisted the help of the secretaries to share that message with the charge nurse, so again, we aren't pulling staff away from the bedside. So I referenced a little bit ahead of communication of our staffing needs. So when we rolled this out, we really wanted to target some support staff. Nurses are pulled in so many different directions, and really their role should be at the bedside, providing that immediate care for patients with their expertise. So we enlisted the help of our unit secretaries on the acute care division to communicate their staffing needs and to be able to provide those updates. And they're absolutely doing this with the direction of the charge nurse, but they're sitting at the desk managing the patient flow, managing the phone calls, just the patient movements across their unit, and they're at a computer and have the ability to quickly send these messages and updates to the staffing office. So we focused on training the unit secretaries. The training that went into it was very minimal. We spent a couple weeks going across the acute care division, catching each of the shifts, day, evenings, weekends, nights, and getting a couple individuals on each unit, on each shift, educated on the process. The workflow of the Hospital IQ workforce management also made it very easy to educate the staff. There was a view specifically for the secretary that did not have what the unit director or unit manager or the staffing office would have, that really honed in on their unit level. So it made it easy for them to cross-reference the staff they had, ensure there weren't any changes that weren't updated in there, and then quickly send verification to the staffing office that they'd reviewed it and that their staffing was current. With that, then the staffing coordinator can log in, see the updates in real time from each of the units that have updated, and then also they have an understanding of maybe who hasn't gotten the opportunity to go in and update their staffing for the day. So they are still making a few phone calls, but it's more of a safety check. Say 6 North didn't log in that day. They can call and say, oh, okay, your secretary called in. You may not have somebody that's trained. Let me help you, and while I'm at it, let me swing by and train that individual. So next time they fill in a secretary, they can help with that. So the training was very minimal. We're still doing it with staff turnover, but it's going very well, and honestly, we've really been successful with train-the-trainer model, where the secretaries are training each other as they onboard new staff. So a lot of the benefits that we've seen from this I've highlighted a little bit, but I'll just go a little bit deeper into those. So our unit leaders were spending just about as much time with the physical, manual, Excel updates of numbers that the staffing coordinators were, and they were really struggling to have that proactive view of what their staffing was. There was a lot of texting between directors on what give and take there was and what changes were made, and they were really struggling to be able to maintain their other tasks, such as onboarding new staff and focusing on quality and safety of their unit. So we really wanted to be able to give some of that time back to the unit directors to focus on what they can do to help their unit succeed and provide that quality patient care and retention of their staff. The transparency of hospital IQ also helped nurture that. So I mentioned a little bit earlier about the silos that our unit staffing was functioning in. The transparency has really helped with that. There were a few units, I would say, that were really great at shared staffing, just kind of understood the need and really bought into the concept. But with that transparency, you had the ability to see maybe some of those outliers that were still functioning in silos that could really be pulled in to the shared staffing and really understand what resources were available on any given day at any time as staffing changes with its ebb and flow of call-ins and census and acuity. Also improved the communication, not only between the units, but also the staffing office. It gives us an easy means to communicate the challenges and the decision-making that's really going into the shared staffing, or why one unit is getting 3 resource pool nurses that day where another one maybe isn't getting any and they're just maintaining at their bare minimum kind of status quo staffing there. So it gave us the ability to quickly communicate what some of the needs were, whether it's sitters, acuity, just looking at what's really going on in each unit, and a means to communicate that quickly with everybody to have the understanding of why the decisions were being made. So reduce the stress, that really speaks to just the concept of this entire presentation. We felt like we were constantly just working in crisis mode with staffing. Each call-in felt like you were just kind of pedaling backwards time and time again to try and then reassociate what numbers were on each unit, figure out what resources were there, and we truly were in crisis mode. 24/7, just really trying to figure out what those numbers were. It doesn't mean that the complete stress of staffing has gone away, but having a tool that helps you understand the resources and the area of greatest need really helps decrease that stress and understanding and fully utilize the resources that you do have, rather than trying to pull in additional when you may already have resources there. I spoke a little bit to the work that the staffing coordinators were doing and how they were walking around and trying to keep up with the fluid movements of staffing with call-ins, acuity, census, admissions, discharges. So we've really decreased the amount of time that the staffing coordinators are rounding, and actually we've even been able to add a few tasks to what they're doing in their day. So the staffing coordinators are able to get their information from the workforce plan. They are still physically rounding to put just a face to the role that they're doing and stay in touch with the bedside staff. And also when they're rounding now, they have the ability to step in and help with maybe some admit discharge work, or just provide another set of hands to a floor that might need a little bit of assistance. We talk in nursing oftentimes when a floor feels like they're in crisis as far as their acuity, their admit discharges, things like that. And oftentimes you don't need another body for an additional 8 hours. It's really kind of those 15-minute increments where somebody's got a change in acuity, somebody just got several admissions, and really just having another set of hands to help with some of that work. And the staffing coordinators are able to do that now, where before they were so busy chasing numbers, they were struggling to be able to be those helping hands, which they currently are. Speaks also to how they're able to allocate unit staff. So we deploy our resource pool staff in real time in 4-hour increments, and they're able to do that quickly. So when a staffing coordinator shows up for the day, they log into Hospital IQ, they evaluate the changes that were made in the workforce plan by the secretaries. They reach out to the floors that may not have had the opportunity to do that, which is becoming less and less each day, and then they're able to quickly determine their plan, send messages to the floors and Hospital IQ on the staff they're getting, and also automate some messages to the staff on where they're going. So the allocation of the staff has decreased time-wise significantly, and that allows them time to be more proactive, look at the rest of the week's staffing, look at the next schedule it's about to post, and see where some opportunities for balancing are and things like that. The staff have also been pleased with this because they're getting notification of where they're going on the nursing units earlier in their shift. They're able to get started getting reports, get their patient care going, rather than waiting to hear from the staffing office where they're going to be. They've also noted that they're moving less throughout their day. So I referenced earlier, a lot of my passion from this is working as a resource pool nurse where I bounced from group to group, and you really felt like you were reactive rather than proactive as a nurse. With this transparent tool, we're able to look ahead at the needs of the floors and keep the staff where they're allocated longer, perhaps for an entire shift. Not saying that we aren't moving staff at all, but the percentage that we're moving staff multiple times throughout their shift is decreased significantly. And as I mentioned before, we're able to see those future staff needs, reach out to staff a little bit earlier. That's another challenge with nursing work-life balance. We were finding that staff were not able to check out when they did have a day off because they were constantly getting text messages and SOSs from the floors that they needed help, come in for incentives, things like that. So now we can be more proactive and maybe send out a week worth of needs where you might be more apt to have staff pick up because they're able to look at their home lives also and work around if they pick up an additional shift or trade around their hours or things like that. And with all of this work, we really simplified the process of allocating staff. It would take multiple hours to determine where the needs were, what resources were needed where, devise a plan, and then allocate that staff, and then ensure all the staff, along with the receiving units, really knew who they were getting, where we can now reference that. There were times where before we were using this tool, it would be a weekend and resource pool staff would be reaching out to their leaders because a text message or a plan wasn't clearly communicated. Well, now we have the source of truth for many to reference on a mobile device for what the plan is if there was a gap in communication. I've alluded quite a bit to the proactive staff planning. So with the time we've gotten back from using this product and not having to physically round and chase numbers for staffing, we're able to be more proactive. So we're looking a week out, we're looking 28 days out, we're looking a schedule out at where we can smooth schedules, trade around shifts, look at PTO approvals and allotments, and if it's really aligning with our census forecast and the staff that we have across a division rather than just an individual unit. You'll learn real quickly that if you have just maybe 2 units out of 8 that are allowing too much PTO off, that's really a burden on the resource pool and the overall division and their ability to staff appropriately for that time. We're also moving staff if we happen to have low census days, which in our current peak season seems like a far-off thought. But if we have low census days, we're able to trade staff to looking at the forecast, maybe a time where there might be higher census, and helps control our cost of staff and then also the burnout of staff. They're not being begged to stay another 4 hours on that high census day. They're truly able to just switch their hours and perhaps have a little bit work-life balance there also. The staffing coordinators can really look ahead and look at some challenges in staffing-wise on the unit level and also the division level. So oftentimes the staffing coordinator is able to look at a problem area a week out, maybe see a problem day, and communicate that to our acute care division leaders. So at their morning meeting, their morning huddle, they can talk about what that next Thursday, where it looks like we have challenges, how can we smooth our schedules, what resources can we pull bedside that maybe aren't, and how can we combat that staffing when we have the ability to see it in advance. Also gives us that big picture, which I just very much so alluded to as a division. We can look at what challenges we have staffing and see what our ability is to flex that staff and really combat the challenges of staffing and serve the needs of our community. As census has picked up, I feel like this work has become even more pressing and just really the forefront of importance of what we need to do as a hospital. With peak flu season and respiratory season, I'm sure many organizations across the nation are experiencing the challenges with census that we are. And oftentimes we communicate to our staff, the community really needs us. So we need to innovate and be able to ensure we have the resources we need for the community demands that come in at any given time. With this work, we have been able to reduce our premium pay incentive. We've really kept gauge on that, and the tool itself helps us understand where we're paying incentive and if it was needed or if we could have perhaps shared resources, which we continue to do. So really helped just understand budgeting-wise on each individual unit and as a division also. So this is just a little bit of the results that we've seen with the work. We've reduced the incentive pay by over 70%, reduced overtime hours by over 20%, reduced time spent allocating staff by 70+ hours. That just really speaks to the constant chasing of numbers the staffing coordinators, the unit managers, directors were doing, and really just pulling together, I felt like in crisis mode as a team to say, what do we do about staffing, as we were constantly learning those new numbers that we weren't proactively seeing. So that really speaks to reducing the chaos of staffing and having that proactive view.
Okay. Well, thank you, Shauna. So what I want to jump into now is talk a little bit about how we did this in the overall system behind it. So first, I want to talk about what we have here, and I think it's important to understand that in order to work with and create a really good census forecast, you have to have a lot of information behind it. And at Hospital IQ, we're more than just workforce. We're actually help our organizations do throughput management, getting patients through the continuum of care as efficiently as possible, and helping with capacity, and then also workforce. And the reality of it is these three legs of the stool, if you will, rely on each other. You need workforce to move patients. You can have throughput problems because you don't have enough workforce in place, therefore you have boarding issues, and you want to have as much capacity and keep the beds open as much as you can so you can move people in. So we're monitoring and managing. We're looking at the OR schedules and predicting areas in that where we're even predicting block utilization and when it might not be used. We're looking at bottlenecks and patient-level issues and helping forecast who should be the patients targeted to be discharged, and making sure that everybody that needs to be in the know is in the know on those patients and the priorities of those patients. So we have a substantial amount of data that's not just workforce that we're using to empower and inform the workforce product. And what we do here is it really follows the same kind of thought pattern on every workflow we automate, and we really did this in the workforce area. It's not about just predicting that there's a problem. It's about predicting it and then automating the processes to make sure that there's really a great layer of transparency around, here's the problem, here's what should be done to solve that problem. And making sure everybody's aware, and everybody's aware of each other's status and how they can work together. And then lastly, we have the ability to do the analysis on the performance and look at that, how well did it work and where do we need to adjust. So it's not just analytics to throw analytics on a screen to show people that they have to pour and spend time over to figure out. It's about how do we position it in a way that we put it in the hands of the right people at the right time. And that to me is the magic of what we did here with Mercy and their staffing. It was make this easy to do the right thing. And we also knew that we had to give back time. Nurses just don't have extra time. And quite frequently when we were talking to CNOs, that's one of the biggest concerns. And we can come in and show that, hey, we're going to actually cut time. We're going to give you time to be more proactive. Keep on hitting the next button. So, and the other thing is that our systems are designed to be very portable and to be utilized in a way that the person, the target, the persona needs it. So we can be on mobile devices and very portable. We can be in an office where somebody can have multiple monitors looking at things, or we can be in a command center where we're on big screens in the command center where you can see what's going on. So we have this ability to transform to the needs of the user. And in Shauna's case, I know she's had times where she's taken care of staffing issues either at home, or I remember once I happened to be at a same conference with her. She was doing solving staffing problems on her phone during a boring session. So it's really, how do we make it very quick and very easy to do what's needed and get it done So we're very portable, and we do morph to the needs of the user. So we're going to highlight 3 really use cases here, and the use cases are, well, you heard a lot about the daily staffing process, and I'll talk a little bit about how that works. And then you get into the weekly staffing and the more proactive piece. And then lastly, we'll talk about productivity and how we are introducing the forecasting capability into understanding tomorrow's productivity today. So in the case of the daily staffing planning, one of the things we do is we come in and we look at the processes, current processes. And what we're really targeting is those non-value add tasks that are happening. So when we look at and we listen to what Shauna said, we attack the process of how does the staffing office validate that what's in the current schedule is accurate. Now, just to be clear, we're not a workforce management company. We work in conjunction with the workforce management and really look at this how do we help you automate the chaos of today and look into the future so that you could actually allocate time and reduce the amount of chaos of today by being pre-prepared for what's coming your way. So we attack the collecting of data, we attack the confirmation of the accuracy of the data, and we attack the time it took to deploy the data. And what we were doing is focusing 100% on the allocation. So we've streamlined the process in a way that the time is spent to allocate and adjust your staffing to the needs of the patient. So that's where the time is getting spent, and that has multiple benefits. First is the time savings of the amount of waste that was happening from just non-productive work, but there's also the time it takes to get your staff aligned to the needs of the patient. By bringing that down to having that take minutes versus the hours that were wasted in collecting the data, we're actually pre-aligning the staff much faster. So there will always be these last-minute adjustments that have to happen if you have somebody call in or you have some weird census fluctuation. But we're minimizing that, and we're making them very quick to deal with. So that's how we get the outcomes of saving that time, so we can allocate that time into the weekly staff planning. And really what we're looking at here is, let's take away these daily adjustments that are being done. Let's flip this chart around where instead of spending all the time on the daily adjustments, we're actually spending very little time on daily adjustments and allocating more time on proactive adjustments. And there's a number of examples of that. But I think, the big thing is the staffing office never got the time to look out into the future prior to this. They were basically too busy dealing with today. The unit managers were spending way too much time, up to 2 hours, on staffing. And by streamlining that, we give them time to look in the future. The unit managers will look at the schedules, and they'll actually even decide if they're going to float their staff to even though they're short on a particular day, they might float staff from a day that they're somewhat short to a day that everybody's short, so they're not the only unit that, or they will be the only unit that has adequate staffing, because they know if there's multiple units that are short, the likelihood of the float pool being able to help them is not very high. So they'll say, well, I'm going to be short on Monday and not be short on Thursday because everybody else is short on Thursday. Therefore, I know I have a better chance of the float pool being able to help me. And they can actually see the status of the float pool in their view. So they know what resources are scheduled for there. So we're really turning this around and making this process proactive. As Shauna said, that we're looking into the future and looking at the long-term schedule to see where are there possible problems and what can we do about it. And again, we sit and we work in conjunction with the workforce management system, so we're complementing that and helping that become more more effective. And lastly, we introduced the process of productivity management or forecasting productivity. And really, because of what we have in the census forecast, we're able to show what productivity is going to be in the future. And to me, this is really powerful because typically productivity management in healthcare is an after the fact. In the best case, you're waiting till tomorrow to see how productive you were yesterday. In many cases, you're waiting a few weeks to see how productive you were, and that causes challenges where if a unit maybe is manager's new and they're not 100% up to speed on how to deal with this, they can get themselves way behind and have trouble then making the adjustments they need to do to get back caught up on budget and hit their productivity numbers. And you know, the more that happens when they're, you know, the only way to solve that is to run lean. And if they run lean, they're putting patient care in a possible risky situation. So what we're doing is we're showing basically the current productivity numbers and showing what the forecast says for patient volumes. And if you stick with the schedules that you currently have, your productivity tomorrow is going to be this. Your productivity the next 7 days is going to be this. And what that does is it changes the process of helping people understand productivity from being a punitive process where, you know, after you find out 2 weeks later that you have a productivity issue, you're meeting with your CNO and maybe your CFO to explain to them how you're going to get back on track, to the possibility of somebody in a leadership level seeing that we're going to have a problem tomorrow and actually going out and taking it as a teaching moment to help people understand what they need to do to solve their problem. Or maybe even figure out that there's not a solution, but at least they did their best. And I would also add that sometimes the challenge in managed productivity is just the heat of the moment. You're a nurse manager, you had some census changes, and you're busy dealing with some patient level issue that is a high priority, and you missed calling somebody before they left for work, telling them that you didn't need them, and they show up. Now you're stuck with them, and maybe it's a little harder to send them home when they're looking at you. And you don't do it, so that gets you in a little bit of trouble. But if you can be proactive, where you have that gift of time, as we talked about in the beginning, you can actually make those adjustments in advance and be prepared for that, or at least let that patient or that staff know, hey, it's likely that we're not going to need you tomorrow, so please call me before you come in, so I can validate that it is what we need. So again, I think as we started, the gift of time that a predictive solution like ours can provide, along with the streamlined workflows and the intelligence we have to make sure we're saving time and putting things in the hands of people so they can react to it really quickly and easily, will drive value for your organization. So with that, I think it's important to kind of land on, what we're out to do here and what we've done here at Mercy is, we want to improve productivity. We want to make sure that the staff is being allocated the best they can. And I would also say improve staff utilization, because in many cases, organizations are running extremely lean and they have far more open positions than they want. And you just can't afford to waste time of somebody. So using a proactive solution where you can see where the adjustments are needed prior to the chaos of the last-minute crises gives you that ability to utilize your staff better. So if you are short-staffed or you are running, you're running lean or you're always running full, the system really still can help you understand how to move people around and how to do the things that maximize their productivity and their utilization. Improving patient care, obviously, it's the core of everything that healthcare organizations do. We want to do the best patient care we want. We want to make sure we're keeping the patients moving through the care continuum. But that is important. But pre-aligning staff to the needs of the patients really can help with that, and making sure that we're maximizing the time that a nurse is working in their core unit, so they feel comfortable and competent to provide the care versus being pulled around and put in situations where they don't necessarily feel competent is a high priority, and then does lead to better patient care. And ultimately, this helps with staff satisfaction. Again, keeping people in better situations, and also I would say from the management standpoint is helping the management do a better job and allocating time back to them to really do what they think is most important, and that is patient care and helping their staff deliver better patient care. On that note, I think that is the end, so we can take some questions.
Wonderful. Thank you, Brian and Shauna, for such a great presentation. We'll now begin today's question and answer session. Please submit any questions you have by typing them into the Q&A box you see on your dashboard. We'll try to get through as many questions as we have time for. It looks like we've already had a ton of great questions rolling in. The first one is, over what time period were the hospital IQ results measured, and how was improved morale measured?
So I can speak to that. So we rolled this out in August. So really the measurements we've been doing was this past August, probably cut off our data point at the beginning of January. So looking at those months and really we did a deep dive in what we were utilizing for incentive pay. We've also done a deep dive in what the floors have had as far as their staffing matching their patient census, and kind of doing it also in real time, but then also looking back and just ensuring what we were feeling we were completing as a staffing organization was really happening. More of the staff morale, I would say, was more personal interviews, talking to resource pool and core staff. We've done a lot of town hall meetings in the acute care division just to talk about not only staffing, but just things in general, but staffing is always a hot topic that comes up. So we've talked about core staff floating, whether or not they felt like they were seeing more of that, and we did also run some numbers to see if they truly were floating or if we were allocating more of the resource pool or the float pool where it was needed. But really just getting to the frontline staff and asking them the work that we're doing, is it helping? Do you feel like your work-life balance is improved? Are you getting less of those crisis SOS texts at home when you're off? Do you feel like you're able to stay and care for the patients that you're most competent to care for when you're on shift? So really just talking to the frontline staff and getting their gauge on the staffing work we were doing and if it was improving their morale and job satisfaction.
Great, and let me ask one follow-up there from the same audience member. He's asking, have you seen an improvement in employee churn as a result?
We have. We are still seeing turnover in the acute care division on specific units. We've also had some leadership turnover, so I think it's multifaceted on where we're seeing that turn. But we've also had 3 or 4 of those individual units where they had rather unstable staffing a few months ago, where they were really pulling on the resource pool, and they've been able to stabilize their staffing to where they're fully hired up to their FTEs. So I guess my response would be that we are still seeing turn, but we've also seen the success in 3 or 4 units where they had many FTE deficits, where they've now been able to not only maintain the staff they've had, but also onboard and maintain those staff that have joined their teams recently.
Shauna, can you talk a little bit about how it's improved the job in the staffing coordinators?
Yes. So staffing coordination in itself is just a high-stress, high-demand job. You're trying to get the resources where they're needed, and sometimes you're making calls where you're pulling core staff or not necessarily targeting the resources where maybe that charge nurse or that floor really feels they need the resources. We actually had a staffing coordinator that started the process when we first started the staffing office before Hospital IQ, and she came back and filled in when we had some FMLAs in the department, and she just spoke to how had we had this system in place and the ability to allocate staff timely and not necessarily chasing the numbers like we once were, that she would have stuck with the role and is now kind of saying, reach out to me when you do have an opening because I'd love to join the office again.
Great, thank you, Shana. The next question is from an audience member who's asking, was floating required of staff before the change, and is it now? And how did you change the mindset?
Yes, so floating was required of staff before the change. So we had an acute care division policy regarding that. So whenever a nurse has been here greater than 6 months, they would float. And then we track the dates of staff that float so that we take turns equally on that floating. We also have the policy where if there was a resource pool, this was before we allocated in the moment, but if there's a resource pool staff on that floor, they would be the first to float. So we did have that shared staffing or floating model in place before we went with a staffing office, and then the workforce model itself. It really did help, though, provide the information and the transparency to stress the needs of helping out each unit and functioning as a division. I think it was hard for frontline staff to see that really we need to come together as a team and be one and help out those units. And now we have frontline nursing supervisors pulling it up and being like, oh, yes, that floor really does need our help, so thanks for helping them out today. So we were already doing it, so we had kind of laid the ground for the shared staffing culture, but it definitely helped add to it.
Perfect. Thank you for clarifying that. The next question is, when you are using predictive analytics, does it provide you the expected demand along with the expected discharges for the day? And how does it incorporate the current hospital census?
I'll speak to our kind of use in patient flow and staffing, and then I'll let Brian maybe speak a little bit more to the product. But it does provide our census forecast, and then along with that, it does show our admit discharges for the day. So we have our census forecast where we can look at the overall inpatient census, but we also have it drilled down to the units broken down. So we have telemetry, we have med-surg tele, we have our maternal child. You can drill down to the individual specific areas and see what your census is going to do. When are the discharges going to go? When are you going to have the influx of patients coming in? And we've even gone as far as predicting our ED borders, which has been really helpful to understand, do we have enough discharges today to meet the demands of what our census will be tomorrow?
And I would add on the technical side, it's really around data. So we're monitoring all the inputs that come through. So we have access to surgical schedules and what's going on in surgery, and we have software solutions that are helping to optimize block utilization and communicate with surgeons. But so we're monitoring that. We're monitoring ED, and we get HL7 feeds of all patient activities. So as current as the systems are sending us data, we know what's going on with the current census. So, and our views that Shauna and her teams work with, they're able to see when they're working with forecasted data and when they're working with actual data, so that it's very clear. So we're keeping track of that in our data with our data feeds and pulling that and keeping that current. So as fast as we can get data, that's what we like. And then our census forecast is continually running. So if there is a curveball being thrown, we adjust to it very quickly, because it will happen, right? There things happen, and you need as quick a notice as possible that things are going in a different direction.
Great, and Brian, we actually have an audience question here about that data. They're asking, what is the primary source of data used to run the solution, and how is that acquired? Would you mind just talking a little bit more about that?
So we're pulling data, and I'm going to say I'm not as big knowledgeable on the patient side as I am the workforce side, but we're pulling data from the EMRs, any type of acuity systems. We're pulling data from the workforce management systems, and we're bringing that all together, any OR scheduling software. So, you know, we basically are very good at getting data into our system. It's typically sent in some sort of a FTE type feed. FTP, secured FTP feed. We can pull HL7. You know, we've done things even pulling data for certain things on secured email, where a client sends us an email with some sources that we just grab the data, Excel spreadsheet out of an email. So we have a lot of different ways of grabbing data.
Perfect. Thanks for that clarification, Brian. The next question is, do you increase your staffing plan due to the flu surge? Does the system account for that? And do you plan out your future volumes using this tool, if so?
Yeah, so actually, I believe it was 3 weeks ago now, we had on a Friday a surge of acuity. The forecast could predict that we were going to stay full all weekend long, so we weren't fully staffed for that. And then we also just had an immediate surge in the ED. So looking at our patient flow, we could see that we weren't going to have enough discharges to meet the demands of our procedure and our ED patients that day. So at that point, we essentially activated just a command team for our hospital, and we pulled in additional resources not only for that day, but we could look at the census forecast and see this surge was not going to let up through the weekend. So at that point, we looked ahead and pulled in additional staff and resources through that following Tuesday, because we could see the census forecast. Not only were the patient volumes going to continue to increase and come in throughout the weekend, but we also weren't going to have the discharges we needed to match those volumes because of the acuity of our patients we currently had in-house.
And our systems are also monitoring CMS flu trends, so we're keeping an eye on, and that's factored into our forecast. So we're keeping an eye on that. So it does feed into to the forecast. We also look at air quality and weather and things like that. I'm told we should be looking at the full moon, but statistically we haven't found anything yet.
Perfect. Thank you both for weighing in there. This next audience member is asking, how do you plan out the week's worth of needs? How do you account for volume changes within that? Or are you working in terms of a base ADC census staffing model that is consistent from day to day that you are trying to cover?
So we do a little bit of both. We do have our average daily census that each unit functions at, and that's kind of where we set our bare minimum staffing requirements that we would like to get each individual unit level to. So that's kind of where our starting point is. Then we also utilize the census forecast to look ahead and see what our census will do throughout the week. So say there are 2 days that are staffed equally on a unit, a Wednesday and a Thursday. If I'm looking at adding maybe a PRN staff member that wants some hours, I would look at the forecast and see which of those days would we have the higher census and add the resources there. So we do a little bit of both. Our ideal just starting point is getting each unit to that average daily census and what they would need for that staff, but then also looking ahead and seeing what our census will do and what the demands of the community will be and how we meet those.
I would also add that a forecast is a piece of information that's to be used with the knowledge and the intelligence of the incredible knowledge and intelligence of the nurses and the managers and so on. So it's just like a weather forecast, if you were planning to have a graduation party this weekend and it's calling for rain, well, you have 3 choices, right? You could adjust your schedule right now. You could make arrangements to get a tent, or you could put up in a contingency plan for, well, I'm going to have I have a friend that has a tent and they said I can come get it if the weather looks bad, so I'm going to wait till Friday evening to make that decision. So if you think about this, and what Sean is doing is they're using a combination of data feeds to make their decisions, but the forecast is just a great another opportunity to give them more input to being much closer to where they were before.
Great. I think that's helpful for our audience to know. We've got another question here about the staffing analysis. This audience member is asking, can the staffing analysis be broken down in 4-hour increments or by shift or by day?
Yes, we actually deploy our float pool, our resource pool, in 4-hour increments. So you can filter the workforce plan based on what view you would like to see. We pretty much function in 4 hours since that's when we allot our staff. But our view has the 4-hour increments for the day and for several days, and that's what the staffing coordinator and the unit leaders are looking at.
Yeah, we have the ability to go down and you can look at it hour by hour if you want, but most organizations do it at a 4-hour level because if you start trying to adjust more frequently than that, it makes it challenging.
Got it. That makes sense. And we have another question here about the timeline. The question is, from the time you began using this product in 2018, how long did it take to stabilize your process before you started seeing such great results?
I feel like with the workforce plan, we rolled it out rather rapidly, and I think it took a couple weeks to get everybody oriented on board, circling back with the unit managers and saying this really is our source of truth. You either need to make the changes in your scheduling software and it would interface, or you need to communicate through the staffing office. I would say it probably took a solid 8 weeks before we were really functional and had everybody trained, using the system, good compliance with it, and up and running to where we felt like it was a source of truth and we could stop the continuous rounding, phone calls, things like that. So I'd say probably 8 weeks to really have it up and running and have the compliance with the product.
Well, within the first week, we were already having the communications that was streamlining the process. So I think the staffing office saw almost immediate impact.
Yeah.
The units, that took a little bit of time.
Perfect. Thanks for touching on that. Another audience member is hoping for a little bit more clarification on floating. He's asking, does everyone float, and if so, between what departments, and how did you get this accomplished?
Yeah, so the expectation in our acute care, and honestly in most of our divisions here at MercyOne, is that we share staff. So there are a few competencies that we do touch on in nursing orientation process on those specialized patients. So we let a patient or a nurse go through 6 months on their individual unit before they're eligible to float. And throughout that 6 months, they're going to nursing orientation where they're gaining some of these specialized skills that they would see on those floors. We also kind of buddy them up with a nurse partner on the floor they float with so that they have a resource there if they have questions. And then depending on the specialty of the floor they go to, there are still some assessment pieces the charge nurse would do. Say you're floating to the post-open heart floor. If there's temporary pacer wires in place, the charge nurse would be doing that assessment for the float nurse or either elbow to elbow with them to ensure that they have the knowledge to assess that specialty piece. It's been our expectation since I've been here at MercyOne 11 years that core staff float. Our ultimate goal is that we're only moving the resource pool, but we do definitely need to expand upon our resource pool to have that goal. There are shifts that we have where it really is only the resource pool staff that are moving, and they're actually a really great resource for those that maybe float to a floor where a resource pool nurse is there too. So it's been the culture here at MercyOne, and I feel that this work has helped us expand on it, although our ultimate goal is those that are competent and volunteer to float our resource pool would be the ones moving.
I would also add that the transparency that's gained through the software and through the process helps them understand that we're trying to maximize them staying in their core unit, and when we ask them to float, we've exhausted all of their opportunities. So it creates that trust that you're not just managing the unit poorly and reacting versus being, this is our only choice.
Wonderful. And then we have another question here about Hospital IQ specifically. Would the system also work for staffing in the OR, pre-op, or say PACU?
Yes, actually, we do have functions to be doing OR in areas that are procedurally driven staffing. So we can look at and match the workload from the different types of procedures that are happening in the OR from the schedule, and actually then make sure that the right staff is there and show the variance of where there are shortages and have that into the future. So we can do areas outside of nursing.
Wonderful. And it looks like we have time for about one more question. And this question is, do you have Chronos or another automated staffing or scheduling system? And if so, do you use this as part of the process?
We do. We have Chronos Advanced Scheduler and then our timekeeping. And honestly, a lot of the changes are made in our Chronos schedule, and then it interfaces with Hospital IQ every 15 minutes. So Hospital IQ is really the tool that pulls all the schedules together and the understanding. And then also we ran into the challenge where maybe there wasn't a unit manager or somebody that had the charge piece license of Chronos on each shift, so they weren't able to make some of those changes in real time. So then they're able to communicate those changes or make those changes in Hospital IQ, and then the staffing office can also help them keep Chronos up to date. So we use the products together, and Hospital IQ really helps us have that overview of the staffing for the division and the ability to deploy the resource pool staff with that roll-up of all of the unit numbers.
Wonderful. Well, that is all the time that we have left for today. I want to thank Brian, Shauna, and Hospital IQ for their insightful presentation and to our audience for participating. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.